I'll do justice to you, Lucene.
Oh, thank you very much.
Hopefully I do.
I'd take the full hour with the fire.
So, by my calculations, it's 10 o'clock, Jeremy, out in Melbourne time.
I think maybe give a couple of minutes for people to come up back and then. What?
I'll be seeing the greetings down there from everybody. Coming, that's great. Just we've got the time span with 10 o'clock in the East Coast here, West Coast Australia and New Zealand. That's what she was saying. I think just 10 o'clock, I might start doing the introduction here now. Is that ready? Are you still there, Jeremy? Go on, Jeremy. Well, I'm going to start this webinar, I think. It's just 10 o'clock, and I know we might have a few more people joining us. I can see the numbers coming up now. So I want to welcome everybody to this ANZ member webinar. And I'm Claire Dickey, member of the ANZ Executive. And I just want to say thank you for your joining us today. And thank you, Lucene, for joining us. It might be an inconvenient time for you being your evening in the US there, although I'm looking enviously, looking in your summer clothes and how warm it must be there, compared with you at 10 degrees. Here's a little bit of housekeeping to start with, and then move on to the introduction. Just looking here at my screen, sorry. So there's some bad audio. I've got a message here. So I'm wondering what we need to be doing about that. Any other
I can barely hear now that we've started, Claire.
Okay.
I hope you can, if you can hear me okay, then maybe we'll be fine once you give the introduction.
Is it better now?
It's very, very far away and broken up.
Okay. I don't know what change there's been from when we did a test before. Is that any better?
No, you know what, but again, if you can hear me okay, once you do the introduction, we'll just make do.
Okay. Jeremy, can you comment, can you hear me in terms of the audience while I'm introducing?
Jeremy, sorry, I was just muted, but I can hear both of you fine. Lucene,
okay,
I can hear
all right.
fine.
So I'll just...
All right, great. Then it's fine. I can tolerate it.
Okay, fine. I'm just holding the phone up.
I'll use my skills.
Okay. What we're doing here, having this phone very close to me, is actually indicating one of the issues today that you can listen to this webinar by your phone or by your computer. And obviously the visuals come on your video and logging in. We found in our test runs that the sound was clearer and better to use on the phone whilst watching on the video. So that's your choice. There may be a little bit of a lag if you actually have a phone and the computer. It may not absolutely lip sync, but you could bear with that. And that dialing in, you can click the sort of speaker message down the bottom of your left screen. You can close off your speaker on the computer. You'll get some feedback if you don't close the computer speaker off whilst you've got the phone on. If at any time the screen freezes, please, you can go to the screen by clicking the blue circle on the white line at the top of the screen, right-hand corner, and then the orange button to reload it. So that's frozen, well, please do that. And if you've got any other technical problems with this, please make a note of the numbers on the screen and dial for the technical assistance. I'm sorry I won't be able to sort it out, go to technical assistance. You would have seen on the left, and some of you are kindly taking advantage of it at the moment to type any messages or questions. And what we'll do is please put your questions in that as you go along, and Lucene will allow plenty of time at the end to answer questions. So I have the honour and pleasure of introducing Dr. Lucene Wisniewski, I hope I pronounced that correctly, from the Emily Program, Cleveland, and Case Western Reserve University in Cleveland, Ohio. And she's the Chief Clinical Officer of the Emily Program and the Adjunct Assistant Professor of Psychological Sciences at Case Western. And she has a very long bio here, which is so impressive, about being the Clinical Director and Co-Founder of the Centre and sort of program. She's got research and clinical interest using empirically founded treatments to inform the clinical program. She provides workshops on CBT and DBT treatment for eating disorders, and is internationally recognised and publishes in peer-related journals throughout the world and invited to write in chapters. And she's been elected to the Fellow and served on the Board of Directors and the co-chair on the Borderline Personality Disorder Interest Group for the Academy for Eating Disorders. And I think that really recognises in our seminar or webinar today her knowledge and skill adding to this field we're wanting to talk about today. And this is her topic today about using DBT with complex adolescent eating disorders. And it's certainly a great interest and importance of our eating disorder work. There are many patients with moderate to severe eating disorders which really struggle with their emotional regulation and have a lot of difficulties. And I know in the SBT may not be enough to actually assist them, even though it's evidence-based first-line treatment. And we might have therapists in these groups are very difficult to treat. So it's really exciting to hear about this today and hear about Lucene and her colleagues' work in exploring the effectiveness of feasibility of integrating DBT with SBT for eating disorders. And as an SBT therapist myself, with an adolescent population, this is really have these complex cases and kids that come with their parents, that we really need something else to help them with their problems. So thank you so much, Lucene. I look forward to the webinar, and I'll turn myself off now and hand over to Lucene.
Thank you so much, Claire. I appreciate that. I want to note, oh, sorry, there she goes. All right, so since it is always a little awkward to be speaking into the Ethernet, someone will just tell me that they can hear me okay, and then I'll know that it's good to keep going. I want to thank you for having me again. It was a real pleasure and always a feat of interweb magicianship, I think, to think that I am here on what is my Tuesday night speaking to you on what is your Wednesday morning. You know, time travel is an amazing thing, so is the internet. And I want to say that at some point, thank you, Olivia, for letting me know that you can hear me well. At some point, perhaps we'll be able to do this the opposite way round, where it's my morning and your nighttime, because if we were having this webinar in my office, you would see a picture behind me. I was thinking about this when I was watching Claire, who had a painting behind her of the Sydney Bridge, or what you might think is the Sydney Bridge, but it's actually the Bayonne Bridge, which is the sister bridge to the Sydney Bridge, which is in my office, because I'm actually from a place called Bayonne, New Jersey, which has the Sydney Bridge, sister bridge, that links up my small town in New Jersey with New York State, a place called Staten Island. So perhaps next time we'll have that other way around, and you can see my portrait of the Sydney Bridge in the background. So when I was asked to speak with you again, last time we talked about motivation and commitment for those of you who were on the webinar last time. I believe that there was a request around using DBT strategies, or how we think about treatment with complex adolescent eating disorders, as there's a large group of you who are interested in work with our adolescent patients. And so, you know, given that we have an hour, obviously I would like to think that my skills are good enough that I could teach you everything you need to know in 50 minutes or less, but I think I would be diluting myself and you as well. So I thought that what might actually be a better exercise is for me to take you through the thought process that went into our program that we have developed and started to do research on for adolescent patients that have an eating disorder but that are considered complex or comorbid, as I think these are the patients that keep us up at night and really require our best efforts at providing them something that's going to meet their needs. So what I'd like to do for you today is to talk to you about the process that we went through in developing what we call the FBT-DBT program here at the Emily program. You'll notice my typo, what the program looks like. That would be the program. A little bit of data, very brief, because again, this is a clinically oriented webinar. And then what does the staff say about this sort of treatment? Because as you will see, I think that in any good empirically based treatment, and remember, most of the data that come from our research studies that inform our clinical practices come from researchers, not always from clinicians. And so I think it's really important to check back in with the clinicians on the ground about, okay, does this program actually work? And you'll see that, and if any of you are working hard to try to straddle the worlds of research and clinical, you'll know that this is one of the main tensions. You know, what the researchers believe that they know to be effective, what the clinicians believe that they know to be effective, and how do you really work and respect both ends of that continuum. So I want to take as the beginning of a case here, a case that I'm going to call RA as an example, and this is one of the early admissions to our program with some of the details obscured for confidentiality's sake. So this is a 17-year-old female who is diagnosed with anorexia nervosa. She shows up at the clinic, we do an assessment, and we find that she also suffers from major depressive disorder, pretty significant with psychotic features. And when she is profoundly depressed, these psychotic episodes result in her making 2 suicide attempts in the past year. So I would call that complex and for certain comorbid. This is a case that also is exhibiting axis 2 traits. She has ongoing non-suicidal self-injury or self-harm. She reports unstable and intense relationships, and you will see that is in particular with respect to a romantic relationship. She reports chronic feelings of emptiness and fear of abandonment. Medically, she's also compromised. She has irregular periods. She has a low heart rate, and her from lying to standing, her blood pressure and pulse jump significantly, resulting in her being dizzy. So she's got a lot of medical issues as well. To add to the clinical picture, this is a kid who is refusing school, is at risk for not graduating or not finishing her junior year when we meet her because she is missed so much school. As I mentioned, she's in an abusive romantic relationship, and that is a relationship that has been emotionally abusive and on the border of physical abuse. She's got significant problems with peers in addition. Now, when she shows up at our center, she's already had a bit of treatment. And as can sometimes happen in these cases, her family has recognized that she's got issues, right? This is a kid who's had depressive issues, and the school refusal go back quite a while. The eating disorder comes on sort of secondarily. So she has had treatment for suicidality. She's had treatment for depression in an individual weekly therapy, also family therapy. She's had treatment for anxiety and school avoidance. None of these treatments have been long-term successful and perhaps not even short-term successful. She's had 2 inpatient stays as a result of her suicidality and self-harm. So this is, showing up a fairly complicated case. Now, when you have a case like this, you want to think, what's going to be the right program? What's going to be the right sort of treatment for a case such as the case that I'm calling RA? And it really involves putting your thinking cap on. And when we first started to, and this is a case that we had originally treated in our, we had a well, I guess we still have it, a standard FBT program. Our clinical programs in Cleveland have, which is in Ohio, have 2 arms. We have an adult arm and an adolescent arm. And in the adolescent arm, and this is really the same in the adult arm, but we're talking about adolescents today, we try to take what we know in research to be most effective and apply it clinically. So we have an intensive outpatient and a day treatment program that are based in FBT strategies and theory. And in that sort of a situation, in a case like RA that I'm describing, her parents were very afraid to put her in a program like that, partly because whenever they would try to ask her to eat more than she was comfortable with, she would threaten with suicide and she would harm herself. There was also escalations that involved the police, more than I think what you would typically see with an adolescent who is being refed, even the most combative. And so we started to think about we have this other piece of the puzzle, another piece of her clinical picture that would need to get attended to, and how do we even begin to think about it? So I want to thank Dr. Carol Peterson, who is my friend and colleague at the Emily program at the University of Minnesota, who shared this slide with me. I used it in my talks when I talk about the notion of marrying clinical expertise with our research knowledge, because it draws from the theoretical base of how do we marry clinical and research. And Sackett proposes that it's a three-legged stool when you are developing new treatment and you are thinking about a particular clinical situation and how do we apply best practices to that case. And the first is starting, obviously, with best research evidence. What do we know to be effective? But really, that is not in and of itself enough. We need to also look at clinical expertise. What do the clinicians think will be useful, and do the clinicians involved have the right expertise to provide this treatment? And then finally, we need to consider, what does the patient think? We could have the best treatments in the world with the best therapists in the world, but if the patient doesn't buy in or see it valuable and doesn't partake in that treatment, it will not be effective. So we need to consider the research, the clinical expertise of the therapist, as well as the patient's values and preferences. So when we were developing this program, the first question is, what did our clinical experience tell us? What did our clinicians say about a case like RA? We knew that some kids were not doing well in our standard FBT program. And we knew this not just by clinical experience. We knew this because we were tracking outcome. And they seemed to be kids who fell into a couple criteria, the kids who didn't do well in our standard FBT program. These are kids who might meet criteria for multiple Axis 1 and Axis 2 diagnoses, so they did not just show up with an eating disorder, they perhaps had other diagnoses in addition. They maybe also had behaviors that were difficult to manage and which were not adequately addressed in standard FBT, and for those we're talking about kids who have self-harm and suicidality. And then there was another group of kids who would seem to do well in our program, but then who would relapse soon afterwards. And these were a group of children that we thought, or adolescents that we knew that we needed something else for. There also seemed to be a group of parents who really had difficulty managing their kids' emotional responses. So that, and by me saying this, I'm not suggesting that it was the parent's fault that the child had an eating disorder in the first place, but that there was a certain subset of parents who really had a hard time tolerating extreme emotional responsivity in their kids, and it would result in their inability to be able to hold limits with the child during refeeding in FBT. So we knew that in our clinical experience, these issues needed to be addressed. Now, what did the research evidence tell us? Well, we know if we're going to talk about a kid this kid was 17, living at home, and was ill less than 3 years, those factors point pretty directly to FBT being the best treatment for their eating disorder, for her eating disorder in particular. But we also knew that DBT really has the best data behind it for multi-diagnostic, difficult-to-treat kids and their families. So, you know, when you have a situation like this where you both have a significant eating disorder, remember, this is someone with significant medical issues secondary to their anorexia and significant comorbidity, depression, suicidality, self-harm. You know, I think classically, as clinicians, we get stuck with where do you start? Which treatment do you start with? And what do you focus on? And I think that one of the things that I didn't want to do is throw the baby out with the bathwater. You know, I think that as clinicians, we can easily feel as though we're supposed to know everything. And I like this slide because it says, you know, trust me, I'm a doctor, like I'm supposed to know. And I think, you know, we really were faced with our own, you know, inability to know exactly what do we do, but we certainly knew that we weren't going to throw out what we already knew from research to be helpful for the symptoms that this person had. But then what does it mean, right? But we'll get to there in a minute. So what did our patients tell us? What did the kids we were treating tell us? The teens told us that they wanted to be able to address issues that may or may not be part of standard eating disorder treatment. So when a kid like RA would come to our standard FBT-oriented program, and they were in a group with other kids who had an eating disorder, they felt both uncomfortable and were frankly told that they couldn't talk about suicidality and self-harm for the protection of the milieu, and because of contagion, which is a real, actual thing. But they wanted to be able to address those issues, and if they felt that they could only talk about their eating disorders in standard eating disorder treatment. The parents told us that they wanted more skills to better help the kids who might suffer from intense dysregulation and those behaviors that scare parents, angry, aggressive outbursts, suicidality, self-harm, substance abuse, impulsivity, you know, where parents really felt like, okay, listen, if you want me to make my child eat, that's one thing. But when she's jumping out of the car on the way home from her appointment because of her dysregulation secondary to having eaten, I don't know what to do. And parents were really telling us that they needed more skills and more ways to be able to think about when their child was having such dysregulation. Staff often told us that they too felt that they needed tools to be able to feel that they were helpful in cases of complex comorbid eating disorders. And I think that in particular, they felt overwhelmed by that notion of where do you even start. And so as we were thinking about, again, taking into consideration the three-legged stool, what does research say, what do our clinicians say, and what clinical expertise do we have, and then what do our patients say, we were beginning to get a picture of, listen, there are significant needs here, and the other, you know, I should say it's not up on the slide, but the other clinical thing that we would see experientially is when you would focus on the eating disorder, and the eating disorder would get better, I guess that's the other way, the eating disorder would get better, the self-harm would increase. And if you would focus on the self-harm and the self-harm would get better, the eating disorder would increase. And it would seem that you were constantly in this situation of focusing on one and the other problem, then coming back up to need clinical attention. And our clinicians were really stumped by what to do about that. So we developed a model for using FBT and DBT simultaneously. And the way that we think about it is FBT principles are infused into and serve as the foundation for the eating disorder management, which will not be surprising to many of you. I'm assuming that this is a group that knows well the research on the use of FBT in adolescent eating disorders, so I'm not going to talk about that specifically. I'm staying kind of theoretical and 50-foot view. But that although the FBT is the fundamental foundation, full comprehensive DBT is layered on top. I'll warn you that this treatment is not for the faint-hearted, nor for the individual who would like to go into a session, put their feet up, and have a nice chat with their patient. It takes a lot of work, and you'll see more what we're talking about. By the way, if that's who you are, that's okay. There's different populations for different ones of us. Now, some people, when we first started to do this work, and I'd say, I'm going to say that we've been doing and developing this program for about the last 5 years. At first, people said, oh, you can't do that. FBT and DBT are diametrically opposed. You cannot actually blend those two treatments. And that really never made sense to me. And if anybody wants to argue that later, we can certainly do it. I've left enough time for us to have some theoretical conversations. But I really actually think that there's a very nice overlap. Number one is both treatments have a non-blaming stance toward the family, right? In FBT, we talk about an agnostic view of why this individual has an eating disorder at this moment. In DBT, we talk about problems that come up in the family and with the patient as therapy interfering. It's non-judgmental. It's really just a description of what issues and interactions that are problematic and get in the way of therapy. So we're not judgmental about it. We really try to stay objective, and I'd say both treatments do that nicely. Both are treatments that empower the family and the patient. In FBT, there's validation of progress at each session. It's very positive oriented. There is significant family involvement in both models. And there's a lot of modeling of problem solving, both in skill teaching and in the session specifically. So I think actually there's a lot of nice theoretical and practical overlaps between the two treatments that make for a nice marriage. But I think we need to step back a little bit, because as we think about, okay, FBT, there's one FBT. We know the FBT. There's FBT for anorexia, and there's FBT for bulimia, but there's not different, really, versions. But when you talk about DBT, actually, there's a couple different versions out there. And so we had to look, when we looked at the literature, we had to have a, sort of little evaluation about which DBT are we talking about. If we're going to marry FBT with a DBT, which one is it? So I'll give you my 2 minutes on this, which is, you may be familiar with this DBT skills manual, which, by the way, is fantastic. It's really well done. It's written by Deborah Safer, Christy Telch, and Eunice Chen, who I believe is from Sydney, who's now she was at the University of Chicago, first she worked with Marsha Linehan, University of Chicago, and is now in Philadelphia. And it's a lovely book, really well done. If you're interested in using DBT for patients who have mild bulimia nervosa or binge eating disorder, for whom emotion regulation seems to be at the central core to their illness, it's really a great book. There have been a couple small studies using this model for adolescents, but it is only a skills model. This is done in a group setting, and it teaches 3 out of the 4 skills modules. And you'll see why in a moment, why I think that that's not exactly sufficient. Although I have to say, I think Daniel LaGrange and Jim Locke are doing a study right now, taking standard FBT and adding some of the DBT skills components to it. So once those data come out, I might change what I'm saying. But for right now, when I thought about what would make the most sense for a complex comorbid case, I was not really thinking that all they needed was just some skills. So again, although I think this is a fantastic manual, it's not the treatment that I was recommending for marrying with standard FBT. By the way, the NICE guidelines say that it's got great results for binge eating disorder and is one of the lead treatment of choices. And again, just so that we're clear, if you turn this book over to the other side, I have an endorsement that I wrote that's published on the back of the jacket saying what a great book I think it is. And It's not for the kids that we're talking about. What about DBT for complex eating disorders? For people where there's comorbidity, significant axis 1 or axis 2 comorbidity, what about DBT for eating disorders with those folks? Well, there's a little bit more data to guide us there, not a lot. There are some studies, one old study by Bob Palmer in the UK, a German group, and then our research group showing that full DBT, and we'll talk about what that means, full DBT in a second, for adult eating disorders, patients with eating disorders with BPD or previous treatment failure, using a full DBT model, and remember that one that I just described to you is just skills, and we'll talk about full in a second, seems like it's got some promise to it. There's also using this same model for adolescents. There's a little bit of data there as well. So when we looked at the literature, we really, for adolescents, we really thought, okay, we want to go with the full model, and I'll talk about why in a second. Now, I want to just say to you that, and I don't know if you have this problem where you guys live, but here in the States, if you tell someone you do DBT, it seems that everybody does DBT. And if you said, you know, well, DBT and eating disorders, and you're going to X, Y, and Z treatment, they'll say, oh, we do DBT and eating disorders. And I wanted to show you how that can be a misleading statement. And when we're talking about marrying these two treatments, I mean something very specific, and I want to be clear about that. So when I first started doing talks on DBT and eating disorders, and the next 3 slides that I'm going to show you are really focused on adults, not on adolescents, but it will underscore my point. And I wanted to get a sense about, well, you know, I'm talking about DBT for the treatment of eating disorders. Who does this? What happened? So in 2004, the first time well, actually only the first slide that I was able to save. I'd done this talk before, but I don't know where those slides are. So in 2004, I found a handful of programs, and I think most of these are in the States, who said that they were using DBT in the treatment of eating disorders. I did this talk again in 2010, and the Google search that I got with the keywords, the search words, DBT and eating disorder treatment, got over 35,000 hits. Okay, so it's growing. There's a lot more people saying or being interested, and these are all programs that in their bios were saying that they use DBT to treat eating disorders. The last time I did this in January of 2014, and frankly I'm a little afraid to do it now because I don't think it'll fit on my slide, it was over 1 million hits. And now there's a lot of people really even advertising themselves as using DBT in the treatment of eating disorders. But when I talk about applying DBT, I'm not talking about, oh, you get a skills group. And I can't tell you how many patients I've seen where they come in and they say, well, I already got the DBT and it wasn't helpful. I was in this inpatient unit or I was in this residential treatment facility and I got DBT and it didn't help me. And I think that we do our patients a disservice when we set them up for believing that having had a skills group or learning a couple DBT skills means they got the DBT or they got the full program. So I want to be clear to you that when I'm saying we're taking FBT and we're marrying it with DBT, what I mean by that is that we are using all 4 components. So comprehensive DBT means includes DBT individual therapy, so with a therapist that's been trained in DBT, and there are certain ways in which we run our individual therapy sessions that are necessary in order to be able to call ourselves DBT therapists, that our patients are attending a DBT skills group at a minimum of once a week for 90 minutes where they're learning the DBT skills modules, all 4 modules. Remember in the Safer, Telch, and Chen book, they learn 3 out of the 4 modules, so they don't learn all 4. That they receive outside of session coaching so that when they are outside of treatment and they need help, that they're able to have access to their therapist for skills generalization and for crisis management. And that is a very different thing than you would see in that same manual, that Safer, Telch, and Chen manual. And all of the therapists that are involved in the treatment of the case attend the DBT consultation team. So it's a pretty tall order here, right? And so again, remember I told you that what I'm proposing, and perhaps there's a more parsimonious way to do this, but I don't know it just yet. I think it'll take some research, but I believe that in order to do this right for a case like RA, we are taking Maudsley therapy, FBT therapy, and layering DBT on top of that Maudsley therapy. So back to our story, okay? We are thinking about this combined treatment. But who do we offer it to, right? So, we're thinking, okay, we have this great idea now. We're going to take full DBT and full FBT, which means, by the way, now you've got 2 therapy appointments a week, actually technically 3, so 1 individual appointment, a family therapy FBT, and a skills group. That's a lot of therapy. Who do we offer it to? It's a pretty expensive therapy. We're not going to offer it to everybody. We have to really be careful in the way that we think about who we're going to offer it to. So we went back to the literature to have a sense about, and we went back to our experiences that I told you earlier when we knew who were the cases that didn't seem to be responding well to our treatment, to our standard FBT treatment. So we went back to the literature and we tried to be systematic. So what did we do? But I want also to tell you, because I think this is one of my public health service announcements. If you are someone, now again, I was trained as a researcher, okay? I was trained, and you may know Walt Kay and Marcia Marcus, who at this point, I think I'm old enough, although I still feel like, they were my academic parents. That's where I went to graduate school. I trained under the both of them. So they are sort of world-renowned, internationally known eating disorder researchers. And so I trained in the best possible scenario to learn how to do eating disorder therapy and how to do research. And over time, and so I really learned about doing treatment the way that it's written and the way that it comes out of the manual. And it does not mean it has to be stiff. It doesn't mean it has to be rigid. It doesn't mean it has to be not connecting with the patient or personal, but it does mean it needs to be by the book, okay? Now, not all research treatments work for everyone, and I'm sure you all know that. What do you do when you have either a case that doesn't respond or you want to try something new, okay? I am now, I would say, 90% clinical, 10% research, but I still hold that value of if I'm going to do something different that's not by the book, that's not in the manual because I want to try something, or I know because my clinical intuition or my reading of the literature suggests that there might be something different that might help this person. It is my responsibility as a therapist to do research myself. And now whether that be just a single case study or some way to be able to track outcomes or to be part of a larger research establishment to study this, it is my job, if I'm going to offer a patient something that's non-traditional, to evaluate it and see if it works. Because our patients, remember that, don't throw the baby out with the bathwater, I'm the doctor. Our patients look to us as we are the experts. And so we owe it to them to be able to evaluate if our novel ideas work or not. So I'll get off my soapbox. But this was part of how we were thinking about to whom were we going to offer this treatment. It wasn't just going to be my good idea. It was going to be back to the literature and being systematic. So I told you that already. So the first criteria for admission, because I work in a tertiary care eating disorder facility, is an eating disorder diagnosis, right? That's a no-brainer. You had to have an eating disorder first and foremost. But that's not enough, right? Because if it was enough that it should be just an eating disorder diagnosis, everyone who came through would be offered this treatment, and that is not a parsimonious way to manage it. So the first thing we did is we looked in the literature and we found the DERS, or the Difficulty in Emotion Regulation Scale, which is a clinical scale and a research scale used to evaluate, as it sounds, difficulties in emotion regulation, which is a characteristic of individuals who have borderline personality disorder or at risk for borderline personality disorder. And we, sort of compared and did some calculations for a clinical cutoff and came up with a clinical cutoff, again, based on what we found in the literature to look at clinical populations versus normal populations. And we came up with a number above which, because we do assess our clients when they come through the clinic, above which made them eligible for this program. So for us, we came up with a number, the score 89. So if it was 89 or above, then they were meeting one of the criteria for this program. But one item is not necessarily sufficient or is enough to suggest that, yes, this individual is clinically complex or comorbid enough to warrant being offered this treatment. So we also, again, went back to our own data, our own outcome data about who was not doing well in standard FBT, and we came up with another list. So this was 2 or more of the following symptoms that we know that DBT is designed to treat: recurrent self-harm, suicidality, substance abuse or dependence, impulsivity with the potential for danger. So these are the kids, the jumping out of the car kids, picking up a knife kids, you know who these are. A pattern of affective instability and disturbances in interpersonal relationships. Again, all of which DBT has specific strategies for addressing. Whether this case presented with a comorbid Axis 1 diagnosis that may complicate the eating disorder treatment. So whether that be significant OCD, whether that be substance abuse, these are problems that would make treating the eating disorder more difficult. If the patient had not been fully helped by standard adolescent eating disorder treatments prior, so whether they were in our standard FBT program and that program had not helped them, notice my language, right? I'm not saying they failed the treatment. I'm saying the treatment failed them, which is very much a DBT construct and important in terms of language and not blaming the patient. Evidence of therapy interfering behaviors while participating in other treatment models. So these are the folks that have been asked to leave treatments because of their behaviors of weight manipulation, throwing food, hiding food, interactions with other patients or staff members, and then difficulty generalizing skills outside of standard treatment. So these are the folks who would perhaps do okay in treatment and then leave, fall apart, and then have to come back to treatment very quickly. So the way that we thought about this, again, so we were systematic. We came up with criteria, research-based criteria, and clinically based criteria based on both the literature and our clinical experience. Now, I'm hoping that if those of you who have questions, because I think maybe you're all still out there, you can be sending them to Claire. I'm going to try to talk for about another 5 minutes and then open it up for a discussion. But if people have thoughts or questions about these criteria, I'd be really interested to hear your point of view. So maybe even a little more simply, when to consider adding DBT to an already existing FBT is, one of the things that we know about FBT is that that one of the predictors of who's not going to do well in the treatment is, we don't have many of them, but we know that if you have not gained 4 pounds in 4 weeks, that you're not likely to actually have a successful treatment. That might be an indicator that DBT would be appropriate to add on to. If there's significant emotion dysregulation, and then some of these other behaviors are the ones that I talked about earlier as well. But so I think I just want to point out that this criteria was for new patients being admitted, and so evaluating it upon evaluation. And these criteria are for an existing FBT treatment and when you might want to add DBT on top of it. So hopefully that was clear. So you're a kid who meets recommended criteria for FBT DBT. Okay, now what? What does that look like? I think that it's important to start FBT right out of the gate. Okay, in DBT, there's a significant courting period where we are trying to get commitment, and we don't start treatment until we get the kid committed to the DBT treatment and the DBT commitment, and we'll talk about what that looks like. But we're not going to wait for that to start the FBT, because we know that we need that FBT and we need that family involvement to be able to help refeed this child in whatever way it entails. Excuse me. So we're starting FBT right out of the gate, while simultaneously working on getting a DBT commitment. Now remember, we had talked about which DBT. There is a specific version of DBT for adolescents. That's the model that we use. In adult DBT, we're asking for a year-long commitment, but a year is an eon in an adolescent's life. We ask for, as is the Alex Miller and Jill Rathis model of DBT, we ask for a 6-month commitment at any level of care, and I'll talk about that in a second. And the DBT therapist's job is to provide motivation and commitment, the telephone skills coaching that we talked about. That therapist has to attend the DBT consultation team and address issues according to the target hierarchy. Now, again, remember, if maybe someday I'll be able to come and give a big, long talk, but in 45 minutes, I'm not going to be able to teach you all of it. But in DBT, this is where the notion of addressing multiple issues simultaneously, DBT helps immensely, because it gives you a framework with which to address multiple issues and where to start. So, I know I'm being a little vague there, given the time frame that we've got tonight, but it is one of the reasons why on a daily basis I think, thank God for Marsha Linehan, because when I'm sitting with an adolescent who has, which happened just recently, who was in the hospital for a suicide attempt, had a fight with her stepfather and threw a glass and hit him, had not eaten and purged twice and her weight was down, and who had not filled out her diary cards when she was showing up for her session, and wanted to talk about the fact that she now thinks that she might like girls instead of boys, and that's what she wanted to talk about. I had in my back pocket a framework with which to address, like, okay, listen, we made a commitment about this is exactly how we're going to address these issues. So, I know exactly where I'm going to start in a session like that. And there's not a day goes by that I don't think, thank God for Marsha Linehan. So the targets, as I said, this is what the therapist's job is, and if you would take that situation I just described to you, we would address the issues accordingly. Target 1 is life-threatening behaviors, and those include suicidal, non-suicidal self-injury, and the eating disorder is target 1 when the individual is medically unstable. And so we have some very specific ways to do that, to evaluate that around, usually it's around bradycardia, or electrolyte disturbance, or some other heart rate irregularity that is considered imminently life-threatening. And when those are the cases, then your eating disorder behaviors are considered target 1. Target 2 are behaviors that get in the way of therapy, non-compliance, non-attentive behaviors, angry or aggressive behaviors get addressed secondly. And third is behaviors that get in the way of quality of life. I thought it would be, remember this is a 50-foot view, when are parents included in DBT individual therapy? Because remember, we've got the FBT happening, so the parents are working to refeed the kid and meeting weekly with the FBT therapist. When are they included in the individual therapy? They're included when they're a central source of conflict with the adolescent, and the adolescent may need more coaching, when there's a crisis with the family, when the therapist determines that treatment would be enhanced with some psychoeducation around DBT for that family, and when the contingencies at home are too powerful and continue to reinforce dysfunctional behavior. So in the situation that I described with the kid throwing the cup at her stepfather, one of the things that became really clear is that when there would be an altercation, the kid would get to go stay in her room by herself for hours on end, and they would forget, and they would stop requiring her to come down and eat. And so we had to talk about the fact that although certainly punishing her for throwing the cup made sense, but asking her to be in her room for extended periods of time was really counterproductive for getting her refed, and we needed to think about a different punishment than sending her to her room, given that it was reinforcing other dysfunctional behaviors. So those sorts of issues would require the parents to come in. Does this all happen in weekly outpatient treatment? It can, but what I've given to you also, again, just as an overview, is we have developed this treatment model to be used at various levels of care. And again, maybe this is another conversation at another time, maybe you'll have me back, but I've given to you the slides here that our comprehensive treatment is a purely outpatient model. And we did it, again, based in researched APA guidelines. So what the American Psychiatric Association, I don't know if you guys, if down under you use the APA guidelines for evaluating different levels of care, but we use that as our backdrop to deciding which level of care a patient should be treated in. So using that, our comprehensive program is our outpatient program. We have taken this model and applied it both to an intensive outpatient and to a day treatment model, with the different services, again, staying true to the theory of FBT plus DBT, but expanding, given the hours that the hours of treatment that the patient may need, given the differing levels of care. We've done a little bit of research on this, and again, I'm not going to belabor this point, but to say I practice what I preach. I told you that if you're going to do something different, you have to study it. This is, I think these preliminary data actually are a little bit old. We are in the middle of writing up the paper for publication right now, and the data look pretty promising. It's an open clinical trial, which means there's no control group, because in the real world, that's not possible, especially in the states where patients are paying for treatment, and we are in a private clinic. But we're doing our best, right? We're continuing to collect data and try to present. We present on this program in conferences, and we're trying to get some data published. So I promised you, too, that I was going to just address what did the staff say about this? What does staff say about working in a program like this that is pretty intense, right? These kids are very, very ill. They can be significantly medically compromised and psychiatrically compromised, as they are usually suicidal or have non-suicidal self-injury, or at least have significant other diagnoses that are interfering with their illness. But the staff say, and this is a quote from one of the staff members, because we collect both quantitative and qualitative data in our evaluations of our programs, I've always really appreciated that there's an FBT therapist who is this is from a DBT therapist, obviously, who is managing a lot of the food issues with parents and clients, which I think has really freed up my work with the client and parents to address the target 1 issues and the TIBs, the therapy interfering behaviors, that really get in the way of recovery. Without the FBT component, I think there would be too much to address and we might not make enough progress. So that the therapists really appreciate it. And you can imagine that the FBT therapists love the fact that there's someone else addressing the suicidality and self-harm, where they know that they can really dive into the eating disorder and not worry that someone's not paying attention to those issues. So I think we still have 5 minutes. I'm going to shut the door now because the dog is outside barking at something.
Thank you, Lucene.
Thank you, Claire.
Thank you for that. I'm seeing one question on the screen, and I've got a number myself if nobody else wants the opportunity. But I think Chris has in there about asking, where is eating and weight gain in the DBT hierarchy?
Yeah, thanks, Chris. Hi, how are you? We think about eating and weight gain in the hierarchy depending on the function of let's see, how do I say this effectively? Because remember now, we're hitting 9 o'clock and I turn into a pumpkin at 9:30. I am in bed at 9:30. So my words start to sound like word salad, you'll know. So eating disorder behaviors are target 1 when the eating disorder is life-threatening. So it has to be the first thing you talk about if the person is medically unstable, because you can't get better if you're dead. That's a Marshall Linehan quote. So if your eating disorder is going to kill you imminently, we need to address that. If you're not medically stable, your eating disorder behaviors, meaning eating and weight gain, could be target 2 if they were therapy interfering. So for example, if you were throwing food during meals with your parents, and then all they were calling me up and complaining about the fact that you were incorrigible at mealtime, that could become therapy interfering. It could also be therapy interfering if you were not eating adequately and not remembering what we talked about from session to session. If it's neither target 1 nor target 2, then it falls in target 3. And for us, because we treat eating disorders, it's the top of the list of our target 3 behaviors. So it is more likely to be the case, though, that you have someone who is medically stable, and they have non-suicidal self-injury or suicidality that have to get addressed first. And then their very first quality of life issue is their eating disorder, because their eating disorder is their main other symptom that needs to get taken care of. I hope that answered it.
Thank you, Lucene. I've got a whole stream of questions here now, so we'll think about how we can do this in a few minutes. It's sparked a lot of interest here.
Sure.
So Mandy is mentioning how it's tricky to set up this in a pay-for-service setting, and could you say more about how clients pay for FBT, individual DBT and DBT groups?
One of the ways that we're able to do this is that you can bill for, one is a family-based code and the other is an individual-based code, and the third is yet a skills-based code. So I think the other way that, so therefore when you have all 3 different, I'm on a conference call. Hi, love. I can't talk to you right now. Go away. I'll be done in 5 minutes. So I will tell you that when we set this up, my secretary has a little bit of time dyslexia, and I told her the only night I can't do is Tuesday night. So when she understood that you were doing this on Wednesday, she thought, oh, it's great, it's Wednesday, not understanding that it was Tuesday night for us, because I'm a single mom on Tuesday night. So, we're still okay. We got 5 minutes. They'll hang on. So there's number 1, there's a coding issue, but number 2 is we have been able to talk to insurance companies around the fact that you've got these complex comorbid kids who usually spend a lot of time in hospital, and that we're trying this model, although it might be more expensive, with the hope that, and we're going to track whether or not we can prevent hospitalization as a result of it. And they are usually more interested than in paying for treatments such as that, because they understand that that's our goal as well.
Thanks, Lucene. And there's a question Rachel said here, and it probably relates to something I was thinking about, is the linking between the FBT and the DBT sessions. And Rachel's asking about, is there any problems having 2 different therapists? And I know I was thinking around that about how they might take issues between, like if something comes up in DBT or things in FBT, taken to other sessions. You've mentioned about from the DBT things where the parents might need to come in, but what's the complexities of having 2 therapists and how they work together on different sets of issues?
Yeah, so the 2 therapists are all we're in the same clinic, right? So there's a lot of communication, both hallway communication, and then we have team meetings where we're talking about these cases. So that helps with that level of communication. The other thing that sometimes will happen is that the DBT therapist will accompany the adolescent into a family meeting so that they can coach the adolescent to be interpersonally effective in the FBT meeting. Likewise, the FBT therapist may come into a session to be able to underscore what's happening in their sessions with the client, with the adolescent's behavior, and asking that the DBT therapist and the adolescent can work on that behavior so that they can be more effective in the room in their FBT sessions. So there is a little bit of crossover. I can't say that happens a ton, but it certainly does require more communication than not.
Right. Okay. probably a kind of related question coming up is about doing DBT within the family context. Sort of, I'm not quite certain Chris has asked that question, whether what you've just said answered that or whether there's a little bit more you could say about that.
Doing FBT within the family context
DBT.
rather than individual therapy.
DBT in the family context.
Oh, he means DBT. I see that now. He corrected it at the bottom. Yeah, you know, because, so I'd say that there's a, remember, we're making this up, right? And we're doing research, and so this is my early answer. You asked me in 6 months, I may change my answer. But that the, during the initial stages of FBT, the family is really very involved in the refeeding, and that the individual therapist is working, doing DBT with the patient, but the family is often very focused on the refeeding. Once the refeeding gets a little bit of traction, there is more opportunity for doing FBT, I'm sorry, there's too many BTs, right? Doing DBT in a more family context, but often families are overwhelmed already with coming once a week and coming to those meetings and really have a hard time keeping things straight. And so that, I think that we don't probably bring them into more of a family-oriented DBT until the eating disorder is a little bit more stable, if that makes sense.
Yeah, that makes sense to me anyhow. And just in case, I'll let you know, it doesn't matter at this stage that your picture has frozen there, but the important thing, we've got your voice. And I think Annalise related to that, because I was asking a question about, are they ever the same therapists, the FBT and the DBT therapists? Like, is it really quite a marker there?
Yeah, we have not done that, partly because the way that we work at our clinic is we try to help people compartmentalize their trainings, and we have very few people who do both, but also our experience has been when they try to do both, something always, they lose track of something. They either fall more on the FBT end or more on the DBT end, and it's really hard for them to be able to switch hats in an effective way. So it's both a practical issue that we don't have many people who are cross-trained, and it's also a philosophical issue in that I'm not sure that many people can do that well.
Yeah, and I'm very conscious of our time, we're a couple minutes over, and can I have a very quick question as a chair's prerogative? Going at the beginning and setting up and talking about the commitment to treatment, FBT, it's really the parent's commitment to treatment and coming. When you're doing with the DBT too, how much of this being the individual adolescent has to be there? What's the difference in the way that commitment is made to the treatment?
Yeah, the commitment is similar in that, well, it's not actually that similar. We really want to get the commitment from the kid, but if we can't, we'll take the commitment from the parents. And usually then the kid is invested in getting their parents off their back, and so we could at least get the buy-in from that end on the DBT end. We're not waiting around for a kid to give their commitment for FBT at all, but we will try to get their commitment in DBT, but if not, we'll take the commitment from the parents instead.
Right, thank you. That's really an important distinction there about that. Look, I could have lots more questions here, and I'm sure others would do, and people will probably have to go as well as you do. So I want to thank you so much, Lucene, for your
my pleasure.
Experience, and we look forward to being able to hear further developments in this, but it's really been quite inspiring today in an area that we're all very interested in. So thank you very much, and thank you everybody for participation and your questions and involvement in our webinar today. And this will be posted on the website in the future for ANZ members. Thank you very much, Lucene, and bye everybody.
Thanks. Thanks, Claire. Take care. Bye-bye.